First of all, thank you for joining our monthly Dunlevie Center Lecture Series. We bring you presentations from luminaries in the fields of obstetrics, maternal-fetal medicine, and perinatal biology. But before I proceed any further, I just wanted to give a few center updates. Our 2023 seed grant proposal RFA has gone out, the deadline of April 18th. And again, these are up to $35,000 available for a 12-month period. And we have more information for those interested on our website. And next slide. We will be having our basic science symposium regarding pregnancy and fetal development, a fundamental discovery. This in April, Friday 21st, from 1 to 5 p.m. It will be in person at the CAM Grand Rounds Conference Room with a Zoom option available, and we hope to have a great showing there. And next month, Dr. Sarah England will be speaking at our monthly meeting. She's the professor of medicine and vice chair of research at Washington University School of Medicine in St. Louis. But today, it is my distinct pleasure to introduce my good friend and colleague, Dr. Vincenzo Berghella, whose talk is entitled Cesarean Section 101. A few words of introduction. Dr. Berghella is originally from Pescara, Italy, where he moved after high school to attend Manhattanville College in New York. He did medical school at Thomas Jefferson University in Philadelphia, OBGYN residency at New York Downtown Hospital in Manhattan, and his MFM fellowship back at Thomas Jefferson University, where he remained and is now the director of the division and the fellowship program. Dr. Berghella has authored an eye-watering 600 plus peer-reviewed scientific manuscripts, is the editor and co-editor of several medical textbooks, such as Obstetric Evidence-Based Guidelines. He is also the author of over 45 medical and non-medical books, including Happiness, The Scientific Path to Achieving Well-being. And in fact, we had to choose between that talk and the cesarean section talk. So we're going to have you back, Vincenzo, for the happiness talk.
Anytime.
Dr. Berghella has been a member and leader of several committees of the American College of Obstetrics and Gynecology. He is an oral examiner for the Maternal-Fetal Medicine Board specialty and is past president of the Society for Maternal-Fetal Medicine. He is editor-in-chief of the American Journal of Obstetrics and Gynecology, Maternal-Fetal Medicine, associate editor of the American Journal of Obstetrics and Gynecology, deputy editor at Up to Date, and associate editor for the Cochrane Review. He's also chair of the MFMU Network Data and Safety Monitoring Committee since 2019. Dr. Berghella's research interests are in high-risk pregnancy, in particular, but not limited to, prediction and prevention of preterm birth and management of labor and delivery. In addition to being a world-renowned educator and clinical researcher, he remains a busy clinician, spending at least 50% of his time caring for patients. Please join me in welcoming Dr. Berghella.
Yes, sir. Thank you very much. Make me blush here, and it's way too much. It's been a great ride, and you know, delighted to be here with you today. Let me share my slides. As I said, I have lots of things to discuss with you. If I may, actually, I'm just thinking of congratulations on amazing faculty and trainees. If you haven't invited Alan Flake yet, you know, who is, as you know, here from CHOP and as the artificial placenta, you should surely do that. I think it'd be perfect translation of the thing. And actually, one of our fellows today, Sarah Budova, gave us a wonderful, she's interested in fetal infection and the fetal immune system. And I think I sort of something like that I'm sure you have plenty of speakers, but if you need more ideas, I can certainly send some.
That would be wonderful. We'll definitely take them. Thank you.
Yeah. I wish I were there with you in person. So quickly, my talk is very clinical today. I think I'm happy to say that there are going to be plenty of research ideas, but very, very clinical. And again, I was of the many topics I suggested, C-section was the one picked. A lot of the think I will say, that they've been published, obviously, and I am the editor-in-chief at MFM for disclosure, and actually the Cesarean part we're about to publish over the next 6 months or so. This is a obviously common issue, for the trainees. You want to be doing research often on things that make an impact. And, when you have 145 million births and over 30 million C-sections, certainly this is something that will, impact lives of mothers and babies for many, many years. And I would say that while this is the world data, and as you know, in the US, we're about 32%, unfortunately, and I'll be happy to give you yet another lecture, yes, sir, the C-section rate is not going to go down, and there are many, many reasons, evidence-based reasons for that. We like it or not. So the talk will be mostly on the technical parts of doing a C-section, since we're doing so many, hopefully for the right reasons. It's upon us to do it well, and I think we have a lot to discover and a lot to discuss on issues before, during, and after cesarean section, focusing on prevention, first and foremost, on maternal satisfaction, so important, that at the end the mom is happy. And again, you mentioned my book, at the end, making baby and mom and the family happy. We're in the best profession in the world, and we need to get these babies out healthy and happy. So this is the latest meta-analysis on music, which we did just a couple of years ago. I don't know if you play music at Stanford or not, and I'm not a musician by any stretch of the imagination, but they're actually, and all slides are about the same, 15 randomized studies, almost 1,300 people randomized. There is so much evidence on this stuff. Sometimes it's not conclusive, but sometimes it is fairly conclusive. And for music, it looks pretty final, that it lowers anxiety levels, decreases opioid use, kind of soothes people, and especially if the mother, the family can choose their music, it's a good thing to do. We have known this for a while, the family-oriented C-section and skin-to-skin, it's good. We have transparent drapes at Jefferson, the mother can follow what's going on, and we have nothing to hide, and can actually, the partner or her can cut the cord and start skin-to-skin, right away. Certainly no harm, and it improves dramatically birth satisfaction, again, based on several randomized trials. We don't pay much attention to room temperature, but room temperature, we usually kind of keep it cool, more on the 20 Celsius, 67 Fahrenheit. If we increase the temperature, there's actually less hypothermia in some smaller randomized trials. And this probably doesn't have much effect on the babies or us, except maybe for preterm babies. As you know, preterm babies suffer from hypothermia more easily. And so if you're delivering a very preterm baby, you may want to consider a warmer room. This is something that's very controversial, and I think deserves a lot more studies. Thromboembolism is still a killer in pregnancies in the US and around the world. We all do mechanical prophylaxis with stockings or compression devices. I don't know how you do it at Stanford. I think most places, if there is one or more significant risk factors like morbid obesity, paraBT, etc., then uses some kind of low molecular weight or regular heparin. But we really, they do heparin routinely in some countries, and I think this is still something that we need to study more. Only 3 small old randomized studies on lateral tilt. I'm going to ask yes sir, once in a while to vouch for everybody and maybe raise your hand. You do that at Stanford, I would think. Yeah, we do that at Jefferson. Again, not too much evidence, but there is some evidence for a little bit better outcomes, as you can see, of course, pHs and oxygen. But really, it's kind of, something we do routinely. We all teach each other, but I think less than 300 women randomized. This could use a little bit more evidence. We probably shouldn't do extra oxygen on everyone. We always think like, let's get the baby, better oxygen. As you can see here, some randomized trials in good journals showing no evidence of benefit. So I don't think anybody I know gives this, routinely. And same thing with shaving, nothing, no good data on routine shaving. It is associated with discomfort, and in non-pregnancy data with twice the rate of infection. So most people recommend clipping, but really for most times you really don't need to do any of this, and you can let the woman be. I love this randomized study from the New York group, from Joanne Stone and her colleagues, published just a couple of years ago, 3 years ago, in the great journal. Large randomized trial. They did 2% chlorhexidine or placebo as you can see, in different body sites. It did actually the night before the C-section, the scheduled C-section, and after the shower, the morning of the cesarean section. I thought that we're going to have positive results. We all have our biases. Really well done trial, but they actually didn't show a change in anything, including the primary outcome of surgical site infection. Again, only one randomized trial, so I think it needs to be replicated. As far as I know, and some of you may know this literature better than me, there is some evidence in non-C-section, other laparotomy, that this is beneficial. This is, I think, pretty settled, that skin cleansing just before you start the C-section is associated with less wound infection. That's really the main outcome, and that it is better than iodine for that outcome. As you could see, Cochrane, which I love, meta-analysis, many randomized trials, and some more randomized studies as well. This is very hot topic that I think should be researched some more. We're certainly doing some research on this here as well. Happy to discuss more questions on these issues. We actually did a meta-analysis years ago with Dr. Simonazzi, who was rotated with us at the time. We found, actually, this is now almost 10 years ago, 8 years ago, that routine tranexamic acid before the skin incision, we found already back then 9 randomized studies, over 2,000 women, and decreases in, hemoglobin, improvements in better blood loss, hemorrhage, uterotonics, blood transfusion, etc., all significant. This is prevention. The talk is really about prevention. Since then, I have been able to change things at Jefferson so that with previous accretas, prior postpartum hemorrhage, maybe twins, high risk for postpartum hemorrhage, we do give tranexamic acid before we start the section, the time of the antibiotic. We don't give it on everyone, which is actually the data in this slide. As you know, there have been trials positive and negative since this meta-analysis. I am a little bit disappointed that the network did the trial given the tranexamic acid after cord clamping, which apparently the FDA forced them to do, so it's not their fault. But again, I think this is something that will be done more and more. And I think in general, the data on tranexamic acid is very, very reassuring. So I trained a long time ago as the assayers say, and we didn't give any antibiotics almost to any C-section. Now we give it to everyone. We give it before the incision. We used to give it after for clamping. Ancef we use usually routinely, and we azithromycin, given Tita's wonderful randomized trial for people in labor after membrane. Is that pretty much what you guys do? Yes, yeah. And we may give a little bit more for obese women, and that's, I think, become pretty standard, which I'm happy about. This is not standard yet, and we have changed here based on some of this data. So first, there was this meta-analysis in the Green Journal we did with Dr. Kaisuti years ago, Iodine, vaginal cleansing before a C-section. We found almost a halving of endometritis. And I was interested in particular in people who had pre-incision antibiotics. And even with pre-incision antibiotics, there was benefit. And people, again, in labor or rupture membranes are a higher risk of endometritis. And since then we published actually in the first issue of the Pink Journal, this study from New York, 1,000 people randomized, and chlorhexidine being better than iodine. We do it here. I know not everybody is taking it on, but there is some evidence for benefit. And again, when we did the sub-analysis for pre-incision antibiotic, on top of getting that antibiotics, this seems to decrease endometritis. And this is the data, at least from Jefferson, our rates going down, and they continue to go down. I could talk forever about pain control in section. I think it's a very hot topic. We certainly received at the Great Journal and the Pink a lot of it's probably with equity issues, one of the hottest topics that we receive papers on. This is a meta-analysis that one of our residents at the time, then fellows, did, looking at gabapentin, something that is used more and more common in pregnancy for all kinds of different reasons. And we actually found that the VAS, visual acuity scores, pain scores, were actually lower if even just one dose of pre-incision gabapentin was used by anesthesia versus placebos. So if you have somebody that you think is going to benefit from this, it's something certainly that it's safe. Something that I haven't been able to change practice, but I'll keep on, plugging along, and hopefully this is another area for more research. There's actually 3 randomized studies that say that there's no need for Foley. Bladder injuries are fairly infrequent, and there were none in these 3 randomized trials. And if you don't place a Foley, the bladder is really not that much in the way. You should know, if you have some experience where the bladder is. Without Foley, as you can imagine, there are less UTIs, less discomfort when you void, no differences, at least in those randomized studies. So just something for you to consider. I haven't been able to convince people here at Jefferson. We still place a Foley. As I'll show you later on, I have convinced them to take it out right away once we use it. And this is something I think some people still do, but there's 2 old randomized studies and a meta-analysis we did 4 years ago. Actually, adhesive drapes are associated with more wound infection. So use drapes, obviously, but no need for adhesive ones. And obviously, from surgical literature, there's good evidence that the timeout, making sure that you're doing the right thing to the right patient at the right time, etc. It's important. So the first 10 minutes, we kind of covered the pre-C-section issues. And I think some of the stuff is somewhat new: music, skin-to-skin, family-oriented, the tranexamic acid, the vaginal cleansing, the gabapentin, the no Foley, and the adhesive drapes may be something that, again, may want you to pay attention to and certainly maybe discuss, in your next Dunlevie's meetings and research. So I'll switch gears now and I'll go into the intra-op part, obviously following evidence-based guidelines. So the skin incision, while there is no randomized studies, there's plenty of decent evidence that a transverse incision it's better. Just remember, some people say, to get the baby out, do the vertical. The NIH data says that you save about a minute if you do a vertical in a primary C-section, and about 2 minutes if you're doing a repeat. So if a minute or 2 makes a big difference, which usually doesn't. But otherwise, I would say 99+% of the time people do transverse. Really not too much evidence which one is better, Drocone or Phanostil. Do you have a sense of which one do you do more commonly at Stanford? Anyone? Phanostil?
I would say Phanostil.
Yeah, so do we. Hopefully, we did a randomized studies on obese women, which I don't think we'll have enough ends, but I think there's the whole controversy below the panels, under the panels. Happy to take questions on that later. Once you enter, there is some good evidence for blunt subcutaneous tissue opening, and then some people use the scalpel, some people use the bovie. I hate when people have strong opinions without too much data. That's why the lecture here. But certainly there is this randomized study that shows that the bovie may be better short term, but we really don't know the long-term effect in terms of scar tissue, etc. So again, another easy to do fellow resident, randomized trial. There was a large trial that looked at all kinds of different things in the Lancet years ago, an important kind of landmark trial. I think you should all reread. If you look at some of the blunt extensions of the fascial incision versus scalpel blunt extension compared to using, the scalpel, the scissors, seems to be better. Again, you probably heard the name Starks, Michael Starks, many years, very famous in Europe. Kind of, many years ago, he was talking about a very blunt C-section. Now that we have some data, I think that he was right on some of the stuff, and there's some data now to say that that technique is probably good. There's probably no need to dissect the fascia off the rectus muscle. I see people do this all the time, to get quote unquote more space. But it is associated with a little bit more blood loss and more pain without, at least in the small randomized studies, much benefit. So at times I try to teach that it's not really absolutely necessary, even if, again, the evidence is very low. It's amazing, this is something that is done, 30 million times in every year, and we have 120 patients randomized to this part of the C-section. We enter bluntly, and I think that that's common sense, kind of level of evidence, which I hate common sense because common sense is often wrong. But I think in this case, making sure you don't put your scalpel all the way to Lupo-Bao makes sense. And we kind of, distend the perineum bluntly, put a bladder blade, and then retractors, people use metal retractors or their hands or whatever, and especially in the obese women, this retractor was used in some randomized studies and evaluated, and that seemed to be no benefit in this meta-analysis of the 6 trials. Again, this is something that maybe me and you may like and may swear by. You have to put that experience, and I'm not saying not to use it. It's certainly not detrimental, but doesn't seem to help really when you look at it in a level 1 data kind of way. Bladder flap, I haven't done it in a long time. I don't think anybody here does it. Again, for randomized trials, and as you can see here, takes a little bit of time and really no benefit. We do not know too much about the long-term effects, so that could be studied a little bit more, but no bladder flap for a long time. The incision on the uterus, it's usually done transverse, as you know, especially for later on, trial of VBAC, and compared to vertical, there's non-randomized trial data saying that it's easier and less blood loss. And then you expand the uterine incision bluntly. Again, lots of data for that. I think it's well good evidence base, and also 2 randomized studies put together in this meta-analysis we did years ago, doing it up and down, opening the uterus and up and down, less extension in particular, and a little bit less blood loss. So we got baby. I got another 20 minutes to get the uterus back up and do some post-op. So I'll go quickly through the rest. This is me many years ago. You should take the placenta out spontaneously with some gentle cord traction. Again, compared to manual placenta removal, which is fun to do and etc., but you tend to come up with more infection and blood loss if you actually put your hand inside the uterus. we do all curette, and I've seen C-sections, I think now in 6 continents, people use sharp instruments, etc. Really no evidence there for anything. We all used a sponge, which is probably fine. No need to open the cervix. There are randomized studies on that, even if she's closed, and okay to use blunt needles if you're afraid to get globe perforated. I like to sterilize the uterus. That's my own thing. I think it's easier to repair. But if you look at the randomized trials and the many meta-analysis actually on this, there seems to be no big difference. So if you want to keep the uterus inside, that's okay as well. I think that this Cochrane, which is one of the largest one I've ever seen, almost 89,000 women in this randomized trials, convinced me that oxytocin is probably not enough to prevent, again, we're talking about prevent blood loss, that carbetocin alone or combination of oxy and meso, oxy and ergometrin, it's better. So I'm been pushing for this and happy to discuss it, but the evidence seems to be there. Well, for uterine massage, which we probably do and swear by, when you do C-section, there is not even one randomized study. So easy randomized study to do uterine massage as C-section. You need to close the uterus, don't leave it open. Easy message. At least do 1 layer. If you do it continuously, it's probably better. I don't lock anymore because some retrospective data say that actually associated with a weaker and maybe incision. And there's a lot of controversy about full thickness or not. Some benefit in some data. And again, single or double layer, if you're certainly looking at short-term outcomes, will be better to do single layer, quicker, etc., less painful. But long-term, there's only 1 randomized studies with very little data and no rupture. So we really don't know for a future TOLAC if it's better to do 1 or 2 layers. And there's different results. I always say that if I'm tying tubes, I'm doing 1 layer. Seems to be better outcomes. If I'm not tying tubes and she's planning to have babies, I usually do 2 layers, even if the evidence for that it's very little. I don't do this on prevention. I randomized study here from Pennsylvania showing no effect. I don't irrigate, again, no benefit. And I don't do an appendectomy, again, no benefit when the appendix looks okay. I don't close the perineum anymore, and this is well known for over 10 years. Some actually benefit from non-closure. It usually finds itself anyway. Obviously, close the fascia. There is some non-OB evidence in the Lancet that smaller bites may be better, but really very little data in pregnancy. I don't put stitches in the subQ on everyone based on the data you see in this slide. Again, I think eventually we will. I don't think we have studied it enough. I don't think these trials have been big enough, but we certainly close the fat, the subQ, if it's more than 2 centimeters, as you know, based on this Cochrane and actually even newer data that show a lot of benefit from closing. With interrupt, I think it was a recent randomized study that actually showed interrupted, maybe it was presented as MFM, either interrupted better than continuous closure of the subcutaneous tissue fat. I used to put a drain during residency 30 years ago on everyone. Please don't put it in. There is no benefit from putting a drain. And again, this is studied in over 5,000 women. We can't, I would take it as an offense to all the thousands and thousands and thousands of women who have, and individuals who have agreed to be randomized in all these trials, all of these authors doing lots of work on all of the randomized studies, so difficult to do, and ignoring the data. It's just, I think I'll put you in jail, in my mind. I think you need to know the data, then you can decide what to do, but at least first you need to know the data. Tanya McKean, one of our fellows, changed the world. She did the largest randomized studies of any of our fellows, and certainly the largest randomized studies comparing closing sutures or stables, and she changed the world, which is what I want every fellow to do. This is the randomized studies that she published in the Green Journal now almost 10 years ago. Less wound complication, better satisfaction, and better cosmesis. If we close with sutures, I can tell you we were biased. I thought the staples were going to be better. She thought the staples were going to be better. We're going to prove the staples are better. Staples were used more commonly in the US. before 2014, now not the way. And then we did the meta-analysis. She wrote a Cochrane as well, and in thin or obese or whatever, we found the same thing. It does take a few minutes to do, but so it's actually longer surgery by 7 minutes if you do sutures, but less wound complications, separations, etc. Quickly postpartum, and then I'll leave it to questions. Pain control, I would think the number one issue, postpartum, but now we have so many things we can do. And at least I'll say that 6 of them you should do routinely. And I hope you do at least some of these. So epidural at and after C-section, evidence-based, level 1, lots of randomized studies and meta-analysis. PAP block, I know not everybody does it, but it's really evidence-based, even on top of epidural morphine. And there is some evidence, we're putting some of this data together now, that actually us surgeons injecting bupivacaine kind of, around the fascia, above the fascia, etc., is associated with less pain postpartum and less opioid use. So really important things to do, and things that we should do more within the C-section. Then we should also do around-the-clock NSAIDs and acetaminophen. The evidence is not overwhelming, but certainly for mitral laparotomy, it does make sense. And there is some evidence for lower pain scores and decrease in narcotic use. I told you already about gabapentin. You could use it just once, as I said, before the incision, but you can even continue that. For example, people that already use opioids, substance use disorders, this is very helpful. And all of the 6 steps that I just described really almost decrease to almost nothing the need for IV or oral opioid analgesia. So the person can, get up quicker and recuperate and go home quicker. Again, if you put the bladder in, I think there's good evidence from Cochrane and other RCTs that you can take it out right away. So that the person can start mobilizing. Good evidence for that compared to 12-hour removal. Ambulation, there is some evidence that even as soon as 4 hours after C-section, assuming the patient is not getting a lot of opioids and feels her legs again, etc., and so she can get up, and that obviously decreases the risk of GI issues and VTEs and venous thromboembolism. This is one of my favorite meta-analysis. When I did this, I couldn't believe the results. So chewing gum, I mean, how easy is that? 3 times a day, you start right away after the C-section. And look at this, all of these randomized studies show much quicker recovery, GI recovery, less nausea and vomiting, less ileus, higher maternal satisfaction, costs next to nothing. I know our GYN oncologist walks around with a pack of gum every morning when he does rounds and gives it to his big laparotomies. We should do the same with our C-section patient. Put it in your orders, in your Epic orders, should be routine. We're finishing this meta-analysis as well, not published yet. There are others in the past. I think there's good evidence that you can actually start fluids, right away after the C-section, and probably within the first 6 to 8 hours, you can start regular food as well, as long as the woman is already walking and feels well. And but no need, to keep her NPO 24 hours like we used to in the past. Again, I think we found 10 randomized studies now on this. Amazingly enough, we don't know what bandage to use. To use a bandage that you put a bandage on the C-section scar, I bet, right, Stanford? We all do. No bandage has been compared to another, but there is one randomized study that you can take it out of 6 hours. You don't have to wait 24 hours, and women like it that way. So I would think that even if it's just one Israeli randomized study, it's well done. And I try to push to take the bandage out sooner rather than later. Breastfeeding, some of this next couple of slides are pretty obvious, and I could use the whole hour to discuss this issue. Start skin to skin, the C-section room, and continue actively working on breastfeeding, and the more lactation consulting and the more support the woman gets, obviously the better she does. Rooming in that we'll do certainly helps with that. All level 1 evidence. contraception, there's good evidence, as you know, for putting an IUD in at the C-section time, more retention, many randomized studies on that. Obviously, if the woman wants it and has been well counseled, during the pregnancy, but very good effectiveness on that. And that, lots of normal activities for which there are not that many really randomized trials, but there's really no good evidence that you should limit some of this stuff, in particular exercise, and if there are non-narcotics, things like driving. So let the woman decide, but you can empower her that she can return to a regular activity, including if she wants and when she wants, sexual activity. We used to keep women, 7 days in the hospital, then 5 days, then 4 days. It keeps on getting less and less. And there's even a randomized studies that says it's safe to send them on 1 day. I think most of us keep them at least 2 days because of the neonatologist, really. And then maybe some here, they want to be with the baby, they're rooming in, they're learning breastfeeding, etc. But I think certainly 2 days, maximum 3, and an uncomplicated C-section is plenty evidence-based. And so that's my last slides. We went over some stuff that I think is somewhat new, and we already discussed the top here. I think using double postpartum prevention, it's going to take hold more and more. Either oxytocin and tranexamic acid or oxytocin and meso seems to be liked. I think that all of this intervention for pain control are really, good evidence. Epidural opioids, TAB, subcutaneous bupivacaine, and Tylenol and NSAID, like I said, around the clock. Again, as a summary, chew right away, ambulate 4 hours, take the bandage out at 6 hours, and within the first 8 hours, you can probably eat. That's my quick, very clinical review on something that's done, every day, thousands of times around the world, and we've come a long way. When I used to give this lecture 20 years ago, there were maybe 100 trials. Now there are thousands and thousands, like I showed you. But I think there's still a lot of areas, like I showed you, that can be improved and can use your help. You guys have done such great trials at Stanford. I can't wait to see the next ones. Thanks for your attention.
Thank you so much, Dr. Berghella, for this nicely paced and comprehensive review of something that we do every day. And when you do something every day, it always runs the risk that we routinize it so much that we don't question it. And so I think it's so important to delve into this data the way you have. I'll start with a question in the chat from a native Philadelphian, Dr. Ron Gibbs.
Hey, Ron.
And Ron asks, I want to argue about your title. This was not CD 101, but CD 801. As a native Philadelphian, I recall the high obesity rate back home. Please review your care on very obese women at cesarean delivery.
Yeah. No, thanks, Ron. It was great. It's great to see you. I know you love Philadelphia, and love to see you back here anytime. Give me a call when you're around. Yeah, obese women, I mean, they're obese enough, as you know, here, that sometimes we need to use a special bed. I think, the issue of antibiotics, needing sometimes more antibiotic, the dose, I didn't touch on group B strep because I saw your face at the beginning and I was not going to go there anywhere near. And I'm glad you asked about group B strep, in particular. But, the other issue about obesity, I think, is the incision, where to put it, especially when they have a pannus. And I know all of us may have, biases one way or the other, or opinions. I won't say biases, opinions, good clinical opinions. That's why one of our fellows did the randomized trials, and I actually have the paper here on my computer, but we only randomized 70 patients, about 35 to do the incision below the pannus, BMI over 35, and another 35 above the pannus. And I think, the early results I can tell you here don't look like they're significant, but we're probably grossly underpowered. I think that's one of the biggest issue. I'd love to hear other opinions, but that I know of, there's no randomized studies on where to put the incision of these women. And obviously that the other big issue is thromboprophylaxis, but I think, moving them early and it's as important as what thromboprophylaxis to give.
Thanks. So
Thank you. Another question in the chat from Dr. Natalie Aziz. Welcome and thank you, Dr. Berghella. For SSI prevention, it's recommended to leave bandage for 24 hours. Can you please elaborate on bandage for 6 hours? And a follow-up is, what is your choice for peri-op antibiotics?
So let me go back to the slides real quick, if you don't mind, and I'll show you again the trial. So can you see the slides still?
Yes.
Yeah, this Dr. Peleg, who's one of the good investigators from Israel, did this randomized study. So that I think is the better data that I know of. His team randomized women to, again, remove it at 24 hours, like we usually do or used to do, versus 6 hours, and found more maternal satisfaction. Didn't really, it's hard to look at outcomes, they don't really get too much more wound infection, didn't look at long-term wound outcomes. So it's not the largest of trials, if my memory is correct. But it was pretty convincing that you can take the bandage sooner rather than later. But again, this is an area that, it's only one randomized study, so I think it's completely open. And we use ANSEF, most of the time, unless they're allergic, severe allergy. Most women, we use ANSEF. As I said in the other slide, we add azithromycin if they're in labor or rupture membrane because of Dr. Tita's, good, large New England Journal randomized trial. And, this is continuously changing. There were trials at SMFM, being presented on this as well. I'm always afraid, and again, I know Ron is on, to give too much, in terms of antibiotics. But if you look at the short-term outcomes, it does look that wound infections are improved. And sometimes endometritis, obviously, as well, in some of this analysis of trials.
Your Capsol, Dr. Berghella?
Say it again?
You weight base your Capsol for higher BMI?
Oh, yeah, we do give, like I showed in the slides, we do give, actually, to tell you the truth, we often give 2 grams to everyone of ANSEF. Some people have argued with retrospective data, and it may be some of you, so if you know more than me, about 3 grams, because of the pharmacodynamics and, the body mass, of women or larger women.
We use that at our hospital. We do 2 for everyone and then go 3 if it's higher BMI.
There you go. We agree.
I must have missed your antibiotics once. I was still seeing patients in clinic with one of our lovely fellows, so I apologize. I missed the antibiotic slide.
No problem. Yeah. I'm happy, to share the slides. Yes, sir, if I can certainly send them.
Right, that'd be wonderful. Thank you, Vincent.
Yeah.
I have 2 hopefully quick questions. One, what has been, in your experience, the hardest evidence-based intervention to change, or an intervention that we routinely do that's not evidence-based that should be? What's been the hardest one to promulgate?
Yeah,
we talked about the Foley, for instance.
Yeah, I think the Foley is one, but I think, if you look at C-section, the biggest issue, I think it's our infections and postpartum hemorrhage, right? I mean, those are the ones, and postpartum hemorrhage continues to be a huge issue around the world. We talked about the antibiotics, so we discussed that already. The other thing, it's postpartum hemorrhage. I am very convinced that oxytocin, it's not as good as, others. There's great evidence for carbetocin. It's better than oxytocin, and it's used in Canada routinely. It's used around the world, but it's not FDA approved, unfortunately. So here, I think the only other option is to use a couple of things. Like I said, there's good evidence for oxytocin and tranexamic acid. People get worried about tranexamic acid and VTE. I think the randomized studies have not, shown that that's an issue, even in high-risk patients. So that's my favorite combination. And I think that will be used more and more, if not become routine, within the next 5-10 years.
Elliot, you had a question.
In following up on that, Vincenzo, I think our biggest challenge in obstetrics is a C-section after a long labor or second stage labor.
Yeah.
For uteroanatomy. And it's very clear that oxytocin, routine oxytocin is not enough. There's a recent very nice randomized controlled trial from University of Iowa, Cynthia Wong's group, looking at the addition of metrogen to with oxytocin and showing marked reduction of transfusion and so forth. And in that high-risk group, I think that makes a lot of sense.
Yeah, I agree, Elliot. I agree 100%. So I try to find any excuse, and most of our women, obesity is a risk factor. Many do have long labors and certainly sometimes longer second stages and stuff. And many, unfortunately, despite our best management, get choreo. And these are all major risk factors, and oxytocin is not enough.
And Elliot, you had a question about repeat versus primary and the RCTs that
Sure.
Dr. Berghella had presented.
Our biggest challenge is in people with prior C-sections or multiple prior C-sections. And I would suspect most of the RCTs for routine C-sections are in primary. And I'm curious how you would modify your advice for women who have adhesions and need, there's need for a lot of dissection often in those folks.
Yeah, I think, Kelly, that we're going to opinion because, as you know, I cannot show you, slides with randomized trials or lots of randomized trials on repeat C-section. I'll throw out something out there that's not really answering your question, but it's something that I see now 3 different databases answering the question at the same time. If people have 3 or more C-section, I think that there's good evidence now that probably 38 weeks, and I'll be happy to be shot. That's okay. Maybe a better thing, because uterine rupture, actually, if you have 4, 5, 6 C-section, does increase. We've looked at CDC, birth data ourselves. Others have looked at our stuff. In terms of the C-section itself, except for surgical technique, maybe you can make an argument for more antibiotics if the C-section is longer, but that's really opinion based on non-C-section, literature. The longer the surgery, the more infection. But I don't think people have, unfortunately, done most of the data, like you said, it's on primary scheduled C-section for prevention. Good question. That's another, again, we're in our research forum here, another great research question.
Dr. Berghella, thank you so much. We are past time, and I'm sure we could keep asking questions for quite a while longer. I'll ask you offline, how do you get post-op day 1 C-section patients home? I would love to learn more about that. But
I haven't been able to convince pediatricians. Actually, some women want to go home right away, as you know. If they have an uncomplicated C-section and all of the stuff I mentioned, they do pretty well. And they don't need that much narcotics and they can go home. But I think for now in the US, as long as pediatricians want the baby in for 2 days, which I understand, I think 2 days is as early as we can send them home.
At Stanford, I'd be happy with 2 days as well. We're drifting well into the 3rd frequently. So, but thank you again. It's been such a pleasure, and we look forward to having you back to talk about many of the other topics that you offered up. So thanks.
Anytime. Yes, sir. Thank you.
Have a wonderful day.
It was great to see you, so many familiar faces, and thanks for your attention.
See you, Vince.
Thank you. Bye-bye, everyone.
Bye-bye.
Thank you. Bye-bye.